Good morning, everyone. I have the pleasure to share with you the results of the MSF intervention during the COVID-19 outbreak in Italy. Also on behalf of my colleague Alessandro Pini from Epicentre and Sara Forlani from the health authorities of Lodi province. Specifically, there will be a focus on the telemedicine project. In February 2020, a locally acquired COVID-19 case has been detected for the first time in Lombardia, in the northern part of Italy, and that was the first signal of an ongoing transmission of the epidemic that rapidly escalated at national level, with a high level of heterogeneity, mainly concentrated in the north. Immediately, the Italian government reacted quite fast and put under control and isolated 10 different municipalities in the province of Lodi and one in the Padua province, and rapidly culminated in a national lockdown that started the 10th of March and ended up in May. That put the epidemic much more under control, with a downward trend in the epidemic curve till the end of July, and then restart with a new confirmation, new second wave, much more under control, minor and more equally spread geographically in the rest of the country. If we look at the evolution of the curve, we see that the amount of cases at the end of April were more than 100,000, and the deaths at the end of April were more than 50,000, with a median age of 60 years old, the patient. The health workers affected at the end of April were more than 19,000. Italy was the first country to be affected by outbreak of COVID, and that was came as a surprise. There was the health system slightly relatively unprepared. The 15 of COVID patients required more than 50% of the bed in the hospital, and that put the system face a lot of pressure and stress. In that context, MSF decided then to put in contact and to liaise with the national and local authorities, and were deciding an intervention. After a national request, we decided to intervene in different regions, 5 different regions, throughout the whole country, with a different intervention. First of all, within the hospital, providing care and managing patients, IPC intervention within prison and nursing home, and health education among the neglected and vulnerable population, like such as migrants. In this frame, the epidemiological support was quite instrumental to design the project, implementing the project, and also monitoring the results. In this presentation, we already said we're going to focus on the result of the telemedicine project. The telemedicine project is a service dedicated directly to patient 12/7, and that has been implemented in the Lodi provinces with the help of Epicentre and Zucchetti for the software. Not the patients that didn't need the hospitalization because there were no severe cases, but there were confirmed COVID cases, together with patients that had symptoms compatible with COVID and they were followed at home. In order to reduce the burden of hospital and distribute the burden among the community, we provide clinical monitoring and home assistance, and also to early identify the patient that the condition could be worsening and that could be readdressed to the hospital. Listed patients receive saturimate and are asked to measure a set of vital parameters twice a day. The system processed the data and generated an automatic gravity score. Depending on the gravity score, the nurses call the patient or not. In the case of a call, the nurse reassess again the situation of the patient to consolidate or not the code. In case of needed, in case of a bad score, a set of emergency team and the emergency team, medical team, was sent to the home of the patient. Therefore, all the patients that were in a stable condition are daily provided of a sort of monitoring and follow-up of the situation to identify early sign of worsening of condition. The site of recruitment were the different hospital units in the Lodi province, different hospital. The materials were questionnaire and database. During this analysis, we're gonna consider the patient enrolled between the 19th of March and 30th of April. If we exclude from the analysis the patient with no available outcome. The collected material accumulated to more than 18,000 questionnaires, with almost 2 questionnaires filled by patient per day as required, with more than 7,000 nurse calls, with a median call for each patient of 15 for each patient, and 69 home visits, 28 of which were done in emergency. The majority of patients that were under follow-up and under monitoring during the telemedicine project, they had resulted in being white, 30%, and green, meaning the majority of them didn't have any major criticalities. A minority, 6.8%, were yellow coded, at 0.65% were red coded. The doctor calls resulted in 585, and 46 patients were put under oxygen with a median age of 54. If we look now at the characteristic of obesity population, we see that for a total sample of 319 patients, the majority of them, 53%, were female, with a median age of 52. On the right-hand side, we can see then the relevance as well of the project of telemedicine in a burden the hospital charge. In fact, we can see the total number of the notified cases during the same time period of the telemedicine between March and April that amounted to more than 1,000 cases. Below, you see the cases enrolled into the telemedicine project during the same time in the same region that amount to 390 patients. That included in the project, the patient included in the telemedicine project was a quite high part of the confirmed cases in Lodi province. If you look at the final outcome, we can see that only 6% of the patients that were followed with the telemedicine need to be re-hospitalized. So they had the vital parameters that were worsening, and 3% were dropped out, so they left the telemedicine project. If we now look at the final outcome, we can see that only 6% of our patients, they need to be re-hospitalized after an average period of monitoring in the telemedicine of 13 days. And 3% were lost to follow-up. The majority of them, they were released after 25 days in average following up in the telemedicine from the program, and 22% are still in the follow-up phase during the analysis of this study. The table here is documenting the characteristic of the patient and the effort spent in the project split by each category. The highest median age is among the group of re-hospitalized, sent back to the hospital after 13 days we saw of monitoring the telemedicine. And in terms of effort for each patient, we see that the median call done by nurse in the categories of release of discharge are 15 for each patient during the overall time period, 8 for the hospitalized. I also would like to raise your attention to the relatively contained number of yellow and red codes. Taking in mind the results, we come to the major conclusion of the telemedicine project. We saw a high proportion of confirmed cases in Lodi were monitored and taken into account in the telemedicine project, a high acceptability by the patient with a low loss to follow-up and high compliance, a relatively low burden for medical teams, low calls for nurses and doctors, a lower exposure for health workers. And also a redistribution of burden between hospital and out-of-hospital medical services has been noticed. Only 6%, in fact, of the patients were hospitalized and no death was recorded. Then, therefore, there is a certain relevance for replicating such a project of telemedicine in countries with limited health capacity and overwhelmed system. And final, I want to thank all the participants to the telemedicine project, the health authorities in Lodi, Epicentre, the team of MSF in Lodi and in Italy, the task force of OCB, and the Ministry of Health in Italy, the Civil Protection Agency, and the Zucchetti Company. Thanks a lot.